All right, what test would help us look at the respiratory system? We're going to look at the symptoms that would make us focus on the respiratory system. And I'm kind of still trying to manipulate this headgear, so I apologize. We're going to look at some x-rays. We'll look at a procedure called angiography, which is studying the blood vessels. I'll show you what kind of pictures we can get from a bronchoscope, and we'll discuss biopsies again, an area of respiratory medicine called pulmonary function and sleep study. So we're off and running. These are some of the symptoms that would make us focus on the respiratory system, and I've put the more technical term to the side of these. So dyspnea is when the patient complains of difficulty breathing. Hemoptysis is coughing up blood. A normal person produces about a cup of mucus every day, but they don't notice it. And so if people start noticing their phlegm production, they have something wrong. A chronic cough, especially one that lasts more than 2 weeks over more than a 2-month period, could indicate that they have something like chronic bronchitis. Airway hyperreactivity is the fancy name we sometimes assign to patients who have asthma. Chest pain, when we discussed in the cardiac lecture, I mentioned that part of the differential diagnosis for somebody who's having chest pain would be problems with their pulmonary system. So if a patient complains of chest pain, we think about anxiety attacks. We think about indigestion, so the gastrointestinal system. We think about the heart, and we think about the lungs, the structures that are located in that chest area. If somebody has wheezing or stridor or other abnormal breath sounds, when we auscultate or listen to their chest, that would make us focus on the respiratory system. We, in most cases, start with the least invasive tests and move to the most invasive if that's appropriate, and in this case it is. So the first stopping point for a patient who we believe has something going wrong in their lungs would probably be a chest x-ray. And this shows you a normal chest film. When you look at x-rays, it's as if the patient is facing you. And so picture that this would be the patient's right side. This would be their left. You can see how a lot of times they put a radio evident tag there, a marker to show you and remind you left side. This would be the aortic arch, what's called the aortic knob, as we move from ascending aorta to descending aorta. This is primarily the right ventricle of the heart, the left ventricle of the heart, and the atria are so tiny they would just kind of fit in this area. So we really don't see their borders very much. We see what's called the hyla, and you can see that it's a little white here. Notice that things that are very dense, like bones, like things like the heart, things that are dense appear white, and air-filled structures should be black. So the primary color of the lungs should be black. They let a lot of the X-ray penetrate, and so it results in a black color. You can see the outlines of the ribs, and as I go back to this hilum area, the reason it's more white here is there are blood vessels that arise from this area that feed the lung. You have lymphatic vessels that are in this area. So it's normal to see that kind of white pattern here. We see a few of those little threads of white come out to the periphery, but for the most part our lungs are black. We can see the right hemidiaphragm and the left hemidiaphragm, and notice how they come down to sharp angles. Those are called the costophrenic. The phrenic is the nerve that paces the diaphragm, and costal is the name to refer to the ribs. So costal phrenic margins. You can see the clavicles up here, and that's one of the ways we see if the x-ray is straight. And we can see the trachea come down and then branch into its right and left main stem bronchi. So an x-ray would be a good starting point. Now that you've seen the normal, I hope that you can pick out some of the abnormal things on this. So I'll give you a moment. If you would focus on the outer portion of the lungs. It was normal to see a little bit of white in this area, but notice these big chunks of things were getting out towards the periphery or the outer portion of the lung. And can you notice that some of them are very round shaped too? If we were to have a round structure in the hilum, it may just be that we're looking at the end of a blood vessel, that it's pointed right at us. Can you see this perfectly black circle? that might represent an airway pointed right at us. And in this middle portion of the chest, we do have blood vessels and airways that are fairly large. But if we were to start seeing things like this, can you kind of see this circle and this circle? Out towards the periphery of the lungs, I shouldn't have any airways or blood vessels that are this large, especially blood vessels. So these look more like calcified lesions. I know that they're dense because they're white, not black, and those would represent abnormal. This could represent someone who maybe is a smoker who has some lung nodules, those circular areas. It could be kind of an atypical presentation of a pneumonia. We have some fungal infections that will cause little radiolucent, or excuse me, radiodense, radiopaque areas that will look like little circles on an x-ray. This person does have nice sharp costophrenic margins. We can see the left, we really can't fully see the right, and their heart looks a normal size. But they do have increased markings, that whiteness out towards the periphery of their lungs that they shouldn't have. This is a CAT scan, and the person is laying down, and again, you always look at an x-ray. This would be your right, and this would be your left. So you've been taught that the heart is mainly a left-sided organ, and can you see that that's true? Here's the person's backbone, and right along the backbone you have a blood vessel, the aorta. We're seeing those pulmonary blood vessels come out here, and this would be taken probably at the level of about your just below your nipples on you. So we've sliced across the lungs like they're a loaf of bread, and again, the lungs should be black, the blood vessels will be white, and we have this big mass or a tumor over here. And it is kind of unique that it's pretty much a perfect circle. So that would be abnormal, and CAT scan can help us see some densities better. We've discussed x-rays and mentioned that typically x-rays aren't very helpful for soft organs like the lungs. But I hope that you've seen just in the couple of slides that I've shown you, even though we're using x-rays, whether they're just chest x-rays or a CT scan, we can see densities, and it would help us because we know the normal density of the lung to pick out abnormal areas. This is what a CAT scan machine looks like if you haven't seen one. And CT stands for computerized tomography. Excuse me. I am going to remind you that this uses x-rays, and so when the procedure starts, the technician would move behind this lead-lined glass panel over here. And frequently the respiratory therapist, if they're on, the patient needs breathing assistance, the respiratory therapist would put on a lead apron to stay with the patient. The patient could be moved through this donut-looking structure, and we could do their whole body, or we could just do their head or their chest. Our machines now cut the patient like a spiral, a helical CT, so it moves down the chest like a big spiral, or moves down the body as a big spiral. And if we were just going to focus on the lungs, we could probably do that procedure in as little as 5 to 10 minutes, depending on the detail that we need. This is a lung CT, and you can see airways. Airways, right, would be dark. They'd be black, filled with air. If they were blood vessels, they'd be white. We can see how the tracheal bronchial tree and the blood vessels kind of trend each other. So we're seeing those come out from the heart. You can see, again, a little bit of abnormal areas. This is what normal lung should look like, and can you see why we call it a tracheobronchial tree? And along those branches of airway, there are blood vessels. And so, what a beautiful looking structure, but I think you could probably pick out this is what normal looks like. We have some abnormal areas here on the right side. We have some abnormal areas here on the left side, and again, that represents increased density in the lungs, such as something like pneumonia. Sinus CAT scan. A lot of times the problems caused in the lungs may be because someone has something like postnasal drip, and so they're ending up with bacteria or viruses being able to move into their respiratory system. Maybe that's coming down the back of their throat and they're aspirating even without realizing it. This is the person, and we are looking at, isn't it cool, here's their little ear, areas into the ear canal. We're looking at the frontal sinuses, so this would be a slice taken probably right in the area under your eyes. You can see that we've picked up the nose, and you can see this person has a slightly deviated septum, and I want you to think which side that would be. So it's always as if the person is facing you, even if they were laying down, so this would be their left nasal passage. Doesn't seem to have as much patency or openness as their right nasal passage. You can see the sinuses occupy a pretty good chunk in this area, and this person has a negative sinus film, meaning they don't have fluid. If they had fluid, that fluid would fall towards the back of the sinuses, and fluid would present as something more white instead of air, which would be black. This just shows you kind of how those newer CAT scans we use, the helical CT or a spiral CT, or a I guess we have a lot of different names on the detail that we get with a CAT scan, but ultimately it will end usually with a CT in the label. We can now, if we slice you like a spring instead of just like a loaf of bread, we can reconstruct that in a 3D image. So when we take x-rays, or when we take other procedures, usually we're taking a three-dimensional object and we're scanning it in two planes, and so we don't really appreciate the 3D dimensional aspect of it. Think back to the x-ray I showed you. We know that person was not flat, but the x-ray was. The CAT scan, we know the person isn't flat, but the CAT scan is. Well, by the use of a computer and the data from that helical CT, we can reconstruct those 3D images so we can see the tracheobronchial tree in this example. You can imagine it would be a lot easier for a physician to explain things to a patient if the patient could see those things in 3 dimensions. MRI. MRI is using that large magnet. We've seen other structures that could be evaluated with MRI, any of those things in the body cavity. And MRI typically is really good for seeing soft tissue detail. And so one might wonder, why do we even mess with having a patient go for a CT if an MRI sees soft tissue better and the lungs are soft tissue? Well, the answer is typically we can get a patient into a CAT scan machine much easier than we can an MRI. If you've had an MRI done, there's an issue that can come up with claustrophobia. Even if it's an open MRI, there's still a point where you're enclosed more in a tube than just that donut opening of a CAT scan machine. Not all hospitals maybe have access to an MRI, but for the majority, most would have access to a CAT scan. And for the most part, if we just need to see the differences in density, the CAT scan will do the job for us. But here's an MRI, and the person's been sliced on a lateral plane, or a mid-axillary plane. We're seeing from side to side on them. It tells you at the bottom this patient has cystic fibrosis, and I think you can appreciate all these big areas that are dilated airways. Look how big some of these airways are out here. And you can see all that impacted mucus that accompanies a patient with cystic fibrosis. Isn't it interesting that you can see the ascending aorta? You can see the structures in the heart, like the right ventricle, left ventricle. So I think you can appreciate the detail, and I've definitely distorted it by making this picture larger than the image that it was taken. As far as the pixelated information, I stretched it way more than I probably should have. Here's an MRI done, slicing the patient like a loaf of bread. So that's one advantage of MRI, is the variety of ways that we can kind of get sections from the patient. And again, you can see those large dilated airways, and think about how we know this is air-filled structure. How would we know this is an air-filled structure? Or we can use contrast with MRI. It seems interesting that it makes sense we'd use contrast with CAT scans because we don't see soft tissue very well unless we put something that helps us see it. In this case, we can do contrast media to someone who has a CAT scan, and it's a little confusing because now some of the blood vessels appear black. Here's your aorta again, and I guess it'll get a little confusing because that looks like this would be in the area of the trachea. And so we have some structures. You know what? That's too deep in the lungs. This is probably an airway and an airway. But regardless of that, this person has that impacted mucus in large dilated areas, and we could definitely pick up, here's normal, what normal lung would look like here towards the front, and all of this looks abnormal. Pulmonary angiography, the process of angiography means looking at blood vessels. And so this one's showing a clot, and when you have a clot in your lungs, it's called a pulmonary embolus, or more correctly, a pulmonary thromboembolus. A thrombus is a clot, and an embolus is a clot that moved. And because pulmonary embolus, the lungs filtered out that clot, it could cause problems with perfusion, with blood flow. So in medicine we call perfusion, or the blood flow portion, the perfusion, and the airway portion, the ventilation. So this person's had a pulmonary angiography, and the number one reason for doing that would be we suspect some problem with the vascular system, and that most likely problem would be a pulmonary embolus. The patient may have complained of chest pain, shortness of breath. The scary thing about pulmonary emboli is that in very few patients do we have a real definitive symptom that says think about pulmonary embolus. And there are studies that are telling us that when we have a sudden death in a patient, and if an autopsy is done, we're finding that a lot of those patients died from a pulmonary embolus that we didn't even suspect. So we do a lot of things in the hospital, like put on special foot squeezers. We give medications into their belly, low molecular weight heparins. Remember, heparin would keep clots from forming. We do a lot of things to try and keep our critically ill patients, especially those in the intensive care unit, from developing clots. A ventilation perfusion scan. So we're going to study the respiratory airways, and we're going to look at the blood flow to the lungs themselves. And the symbols in medicine for ventilation is V. That makes pretty clear sense. But the symbol for perfusion is a Q. And so we're going to shorten the name of this test to a VQ scan. The number one reason for doing a VQ scan is to look for pulmonary embolus. And VQ scan and pulmonary angiography have been the gold standard, the test to do to screen for pulmonary embolus. However, with the multi-detectional CT scans, with our helical CT scans, we can see those larger blood vessels much better. And so we have seen a change in what we consider to be the gold standard to move away from this very invasive VQ scan or pulmonary angiography, the one we just looked at, and move to using helical CT to screen for pulmonary embolus. What you're looking at here is a normal VQ scan, because we still see these done from time to time, but definitely much less than we had. This is done in an area of the hospital called nuclear medicine. And the patient for the perfusion portion of this test, and these all show perfusion, would have been injected with radioactive nucleotides. Those would have circulated through all their body parts, and in this case the lungs primarily is what we used a scope to then measure that radioactivity. If you see, you can see the outline of the lungs, you can see where the heart would be. So this is a anterior view, a posterior view, a left posterior oblique. So we're seeing primarily this side of the left lung. The person's turned their side a little bit. This way they've turned to their right side a little bit, right posterior oblique view. And you can see that the lung received blood flow to every part of it. Some parts received more, and those are the blackest parts. We're then going to match that to the ventilation that the lung received, because in the body we'd like ventilation and perfusion to be matched 1-to-1. So when I see a really dark spot of the blood flow up here, I should have that same kind of dark spot down here on the ventilation piece. And isn't it unique? You can see that in almost every case. This is kind of one exception. It looks like there's a lot of ventilation at this right lower lobe area of the lung, but it doesn't look like there's as much perfusion there. But the key thing being, every part of the lung received ventilation. Every part of the lung received perfusion, blood flow. If we had a blood clot, think of which picture that would impact. Would it affect the ventilation piece primarily or the perfusion piece? So let me show you an abnormal one, and let's look at what we have. So we have the perfusion on top, and the different views. We have the ventilation on bottom and the different views. And we're looking to see, did ventilation go to every part of the lung? So we can see the trachea, we can see the lungs. We have that kind of section missing a little bit because of the heart blocking those radioactive signals from getting through as much. But we can see that for the most part we might have a little bit of a shallow area here that didn't receive too much, but we've got significant distribution of ventilation. On the other hand, look at perfusion. We have some kind of areas that received a lot of perfusion, or maybe a more normal perfusion, and we have areas that received no perfusion. So what would have had to have happened to have no perfusion get to what would be your right upper lobe of your lung? Well, this is how we diagnose pulmonary embolus then. Because the abnormality is in the perfusion part, that would mean the blood vessels are what's wrong. And so there's either a tumor blocking the blood vessel, or it's more likely that it's a blood clot. So a VQ scan, if you hear of a patient who has one of those, the number one reason for doing it is to check for a pulmonary embolus, or we suspect a pulmonary embolus. Bronchoscopy. So we've had this term before. We've done cystoscopy, and remember my favorite word, esophagastroduodenoscopy. With bronchoscopy, we're going to study the structures in the, I guess, the larger airways we can get to. We can look at the trachea. So this would show you. It seems cruel and unusual, but a lot of these patients are awake and just sedated. We'd like them to be able to follow commands such as take a deep breath. This one shows going through the mouth. Typically, if a person's more awake, we go through the nose because we don't stimulate the gag reflexes as much. So this scope has been put down, and you can see the physician has a screen, or he could also look through an eye scope here. This has a channel that's large enough to pass those instruments. We've talked about brushing, washing, and biopsies that could be done through that scope. So this orients you to the part of the trachea we're looking at. Here's what represents normal. You can see those cartilage rings that we know about in the trachea from anatomy and physiology. The overall appearance of the trachea should be kind of that pale pink. On the other hand, look at this person who has a large tumor. Now, if that was completely blocking the airway during both inspiration and expiration, they wouldn't be alive. So this is a movable tumor, and you can see that when they breathe in, they might have stridor. They might have that noise when they breathe, and when they breathe out, it would probably be easier because it may move that tumor more out of the way. These are those tools. So we could pass down the brush, so we could sample a tumor or that tumor that we've seen. We could get biopsy, so this shows you both ends of that biopsy instrument. This one, your thumb goes here, fingers go here. I bet you've used something similar, a grab bar or a grab device or something. And that would either open or close these little sharp nips on the end. The washing piece would be to put sterile saline down through the scope and then suck back some of the fluid or liquid. So we could do brushing, washing, or biopsy of different abnormalities that we see. All right, closed lung biopsy, open lung biopsy, all of those are options. If someone were to have a tumor, we can actually try and identify, is it in the large airway or the small airway based on an x-ray. That tumor may be in the lung tissue itself. And so if we think it's in an airway, definitely bronchoscopy might be the way to sample that tumor or nodule that we're seeing. If someone were to have a abnormality on x-ray that looks like the right upper lobe is always blocked, it might be a good idea to do bronchoscopy. To wash out or be able to see. So I talk about procedures being therapeutic or diagnostic. Bronchoscopy could be both. If you had an area that's totally blocked, can you imagine you could put a bunch of saline down and rinse out a large mucus plug? And that would be therapeutic, but it would also be diagnostic because we would have been able to see what's wrong, or if we had a tumor there. We can use lasers down that scope, and they could actually do a surgical procedure through the scope. Well, the reason I mention that with the lung biopsy is if we have tumors out in the lung, the options that we might use, one of them would be a closed lung biopsy. So this shows just making small incisions in the patient's chest and using these camera-like instruments to take out portions of the lung. So they're showing you that small sample they're taking out. They would use fluoroscopy, the moving x-ray, or ultrasound to help guide where these instruments go, or they might have a camera on this that would help the physician see. If we think it's in the lung tissue, we could still do a bronchoscopy. There's a thing called a bronchial, meaning let's go through the airway. So we're going to go in the airway, and then we're actually going to puncture through the airway to go into the lung tissue itself, if we think that we could get the tumor that way. So obviously if a person had a tumor out towards the periphery, the edges of the lung, we wouldn't use bronchoscopy to do it because it only gets us to the middle part of the chest, the larger airways and the lung tissue around those larger airways. Remember we showed the picture where the tracheobronchial tree gets smaller and smaller and smaller. And so if we have something out towards the periphery of the lung, we're pretty much going to have to go with a biopsy. This is showing a thoracentesis, and you have an area called the pleura. Remember, the organ is coated with a pleura, and in the case of the thorax, the ribs are coated with a pleura, and those stick together and make a potential space called the pleural space. Well, normally that has just a small amount of fluid in it, and this one shows here's the lung tissue, and normally the lungs should be tight against the ribs with just a little bit of fluid there. And can you see that there's a lot more fluid in this person? A thoracentesis, anytime we talk about centesis, we're using a needle and we're placing that in a cavity. With abdominal centesis, we're putting it in the peritoneal space. With thoracentesis, we're putting it in the thorax. And the purpose of this would be to remove fluid from the outside of the lungs. So it's not fluid that's inside the lungs. It's fluid that's trapped between the ribs and the lung lining. The way we would have identified it, and this kind of shows you what it would look like, so it's showing the lung got pushed out of the way, and that fluid, because it's free floating in this space, would fall down towards the bottom, and that's why we looked at those costal phrenic margins. This one would show a nice sharp corner. This one would show white in that corner, so we'd know that there was some sort of abnormality there. On an x-ray, we can move the patient and that fluid would move, and that's how we distinguish is that fluid in the lung or is it on the outside of the lung. If it's in the lung, it's not going to move that quickly. If it's between the lung and the rib cage, it would move when we move the patient. So they've laid the patient down. Remember, the normal lung should be black, air-filled. Look how much fluid. About half of this person's lung is filled with fluid. So here's how big the lung should be, the B line, and it's showing that that fluid is occupying about half of that space, at least half. So the person has been prepped. We've just cleaned their skin with an alcohol wipe and betadine wipe. They've been given a medication that numbs the skin, some lidocaine, and the physician has inserted a needle into that space and is drawing back. And this one shows the needle that we use. There's a hard solid needle with a soft flexible catheter that can pass through it. And they'll try to only use this sharper needle just to get into the space, and then they'll pass through that hollow catheter, and that's what would be used to draw out that fluid. So if this was thick, pussy fluid, isn't that a nice topic? It's not going to be able to come through that needle, so we're going to have to anticipate that it's fairly thin fluid. This person, you can see it looks like they have a mixture of some old blood. They actually have this kind of layering out in this bottle. And this would be about the size of a 1 liter. If you drink big slams, you know about 1 liter bottles. The most I saw on a patient is they drew off 7 liters of fluid from one lung, from one pleural space. And can you imagine that the patient said, I can breathe so much better. So if that pleura is filled with that much space, or excuse me, that much fluid, it does compress that healthy lung that should be there, and make it so that it doesn't have room to expand. And so we need to sometimes do a thoracentesis. This fluid would be sent for testing to see if it has bacteria or viruses. One reason for having a thoracentesis develop would be cancer, and so we would check for cancer cells. Another reason could be an infection. If you've ever had a swollen joint, it's your body's way of saying, hey, it hurts here. Maybe if I add a little bit more lubricant, things will get better. Well, your lungs can get infection, and the lining of your lungs could become irritated. And the body, in trying to fix the process, could think it would help by just adding more lubricant. And so that might be just the simple cause of it, is that there was some sort of infection. So thoracentesis, we could have a patient who just kind of leans back a little bit to make that fluid come towards the posterior part of their lungs. And we draw off that fluid. We could collect it in some sort of container if we think there's going to be larger amounts, and we're going to send those to be that fluid, some of it, to be tested. Pulmonary function testing. What if a patient complains of shortness of breath, and we want to find out if it's something like asthma? What if we have a patient, a mom who brings a child in and says, every morning at 6 o'clock I hear them wheezing, but by the time the day goes to where the doctor's office is open, it never happens again. And so we might have someone come in to have some challenge tests. We can give some medications, or we can use cold air and try and trigger an asthma attack so that we have a record of, yes, this person does have that condition. For some workman's compensation claims, somebody might do pulmonary function testing. For the first responders for the 9/11 bombings, because they were exposed to so much dirt, I guess not so much bombings, but the trade towers with the airplanes impacting them. Those people were exposed, those first responders were exposed to a lot of particulate debris. And so they've been following those people with pulmonary function tests to see what will happen to their respiratory function, maybe because of things they were exposed to. This person is undergoing pulmonary function testing, and this is showing a really simple procedure. The data that we collect looks at your breathing, and so if you could just breathe normally, this would be inhalation, exhalation, inhalation, exhalation, and now I ask you to take the deepest breath in that you can, and then blow it all the way out, and then breathe normally. And we could do other procedures, but that would be the bulk of it, is looking at your capacities and volumes in your lungs. So there's a lot of initials here, and it's not important to remember all of them. What it is important to do is look at V's would be volumes and C's would be capacities, and that a capacity is always made up of 2 or more volumes. So the quiz is not going to say which 2 volumes make up the FRC. If you're a respiratory therapist, you'll have to learn all those things, but if you're in the Introduction to Lab Values class, it's enough just to know when we do pulmonary function testing, we're looking at the ability of the muscles of the respiratory system to do the work, and the airways to be able to have that gas conduct through them. This is what the results might look like, and here we go again with capacities and volumes. But now we're going to focus on flows also. And I bet if you look at these labels, here's L, you would know that means liters, and here's L/S, liters per second. So if I see a label of liters per second, that would be a flow rate, and these other ones that are just liters are going to be volumes. So we have volumes and flow rates. And if the flow rates are lower than they should be, we call that obstructive lung disease. The airways are obstructed. They could be obstructed with mucus. They could be obstructed with narrowing, such as with asthma. If somebody has lower than normal volumes, we call that restrictive lung disease. So imagine if you have healthy lungs, and I ask you to exhale, and then I put duct tape around your chest. So if you know what duct tape is, or if you don't, just imagine you have tape now strapped around your chest. And I say, okay, now breathe. You'd find it really difficult to take a deep breath. You'd have it a difficult time exhaling with very much force because you don't have the ability to take a very deep breath. Your airways are okay, so you wouldn't have obstructive lung disease. Your flow rates would probably be okay. However, your volumes would be decreased, so your lungs were restricted. Restrictive lung disease decreases the volumes. If, on the other hand, I said, okay, you can breathe fine, except I'm going to give you a little straw to breathe through to represent your lungs all being, your airways all being narrowed, you can imagine that your volumes might be okay. If I give you enough time to inhale and exhale, you could probably take a fairly deep breath. But if I said blow out as fast as you could, you'd have a hard time getting much air to move through that straw. So that would be obstructive lung disease. So let's look at this person. Here's what we predicted they would do, and those predictive nomograms are based on their their height, their weight, their sex, and their race. We do have interracial differences here, with Caucasians having the largest lung capacities. So we're going to compare you against other people that are your height, your weight, your age, your sex, and your race, and we're going to come up with predicted values. Then we're going to measure your values and tell you the percent of predicted. And anything over 80% of predicted, and some places will drop it as low as 75, but typically anything over 80% of predicted is considered normal. So this person had normal volumes. They had normal flow rates, as much as we can tell, the ones they did. So this person does not have restrictive or obstructive disease. Here is another test we do with pulmonary function testing, and it's called spirometry. And this is a flow volume loop. It looks both at volumes on this axis and flow on this one. So if I were to have you take in a deep breath and then blow it all the way out, I could look at your volumes and your flow rates. If you had restrictive lung disease, remember it was as if your lungs were duct tape. Do you see the pattern of this is pretty much the same shape as normal? It's just smaller, a miniaturized version. Look at obstructive lung disease though. And typically the person won't have a problem with inhaling as much as they would exhaling, because it's the airways. When things are narrow, it's much harder to get the air blasted out of there. Now if it was a tumor, it might have moved out of the way. So the shape of this can kind of help us tell the difference between a fixed obstruction and a variable one that might move out of the way versus one that stays there. So here's another patient, and you can orient yourself again. Remember, these are volumes. These are flow rates, the ones that have liters per second. So here's a flow rate. Here's their predicted values, here's their measured values, and here's their percent of predicted. They didn't do very well, did they? So they had a problem both with obstructive lung disease and restrictive lung disease. And the intent of this was to do the measurements and then give the patient a bronchodilator, something that would open up their airways, and repeat the results. And if you remember, which of those values looked at the airways? Was it the volumes or was it the flow rates? If we give the patient the medication and their flow rates improve, if their obstructive disease gets less, then we can prove to an insurance company or whoever, we know that the best thing to do is give the patient that medication that relaxes the airway. Well, this one says the patient was so fatigued and dizzy and short of breath that they weren't even able to do the breathing test. So they're telling you, take these and don't really do a whole bunch with them because the patient wasn't able to give their best effort. And unfortunately, spirometry does require a patient's cooperation and effort. They did some other things here. They did exercise pulse oximetry. What was the person's oxygen level in their blood when they were sitting, breathing room air? What was it after exercising for 1 minute, 2 minutes, resting? And you see they had to stop the test. Their heart rate should have increased as they exercised. And in this case, the heart was overwhelmed and started to decrease. And when we have their oxygen level, their oxygen value here, 89, is still probably within a safe range. You and I would have easily in the mid-90s. And I guess this is a good point to tell you, heads up for next week. We'll have some information on blood gas assessment. And if you've happened to have pathophysiology, you've had an instructor that's taken you through that process, it helps, definitely. It takes practice, and so I'll try and get those notes posted early so that if you wanted to, you can get on and kind of do a preview before you have next week's lecture on blood gas interpretation. So I'm not going to spend much time on this blood gas results here, as we'll do that next week. Let's do a couple last things here at the close of this lecture. One, respiratory therapists deal with sputum. It's a fact of life. We talk jokingly that respiratory therapists have sputum scrapbooks, and as much fun as we make about it, I would be remiss if I didn't tell you that if you haven't decided what you want to be when you grow up, but you know you want to do something in healthcare, you'd probably be remiss if you didn't at least take a look at respiratory therapy. Respiratory therapy, if you like patient care, or you think you do, next to nurses, we are at the bedside, the profession at the bedside the next most. We definitely work primarily in hospitals, but there are respiratory therapists employed in central district health departments doing asthma education or in doctor's offices. Respiratory therapists can be full-time researchers. They may do marketing and sales, so if you say, gosh, what happens if I get burned out in patient care? There's definitely still options open to you. Respiratory therapy is a fairly new kid on the block when it comes to healthcare professions. There's fairly good mobility as far as market demand definitely is strong. Management positions are still fairly easy to move into, and it's definitely been a profession that has treated me very well. There are definitely day-to-day routine functions that a respiratory therapist does, but if you like blood, guts, and trauma, there's an area of respiratory care for you. If you like working with the neonates, respiratory therapists are employed in neonatal intensive care units, pediatric intensive care units, surgical, medical, cardiac intensive care units, trauma. 1/3 of the life flights across the nations use a respiratory therapist as one of their 2 team members that go on their calls. So the sky's kind of the limit, and I'd be more than happy to speak with you if respiratory therapy isn't something you considered. Sputum sample. Back to that. What would be the benefit in getting it? Well, if we collected it first thing in the morning, it may contain cancer cells. So if we're seeing a patient's chart that we need to collect a morning sputum for 2 or 3 mornings in a row, that tells me they're probably looking for cancer. If they're collecting a specimen for a special type of culture called an acid fast, I know they're checking for tuberculosis. So the purpose of a sputum sample is to see what kind of organisms do you have growing in your lungs, and your lungs should be intermittently sterile. So there really shouldn't be a whole bunch of organisms there, but if you've had secretions coming from your lungs, remember I mentioned that a healthy person produces about a cup of mucus every day, but they don't notice it. So if somebody's noticing their mucus and it seems to be an ongoing thing and the doctor's hearing crackles, which would be indicative of pneumonia, they may have us do a sputum sample. This is a fairly new area of medicine, of respiratory medicine, called sleep studies. And you can see that they have all sorts of probes put on this person. And let's go through some of these. This one goes around the chest. It's going to look at chest movement. There'll be a similar one around the abdomen that would look at movement of the diaphragm and abdominal area. This probe on her finger would look at oxygen saturation. The thermistors, or the little devices under her nose, would look at airflow. These devices could look at movement of the mouth. There are probes that are put on the temporomandibular joint movement, or joint area, and the jaw. You know that you hear of people who grind their teeth when they sleep, or who would move their jaw a lot. So they would have measurement of those. They've got probes, and this one only shows one. Usually they have more than that on the head, to actually look at an EEG, the electrical pattern from the brain. They could have probes that go by the eye that look at rapid eye movement. If you've learned about sleep, you know that the part of sleep that's we have different stages of sleep, and some are more restful than others, so they would look at that rapid eye movement. They could look at sound. They may have one of these devices that's measuring sound over that voice box area to listen for snoring. They would have a camera on the person. They would have arm legs and limb legs. If you watch the Seinfeld episode where he has the Jimmy legs, you probably heard something on a commercial about restless leg syndrome, so they can screen for that. There are more recent studies telling us that perhaps some of the children who have attention deficit disorder and have been diagnosed with that have really had a misdiagnosis of sleep apnea problems or sleep abnormalities. So we're seeing many more children being studied by sleep studies. With a sleep study, the person would come in about 7 or 8 in the evening. They would have a technician who puts all of this equipment on them. And you say, how could they sleep? Well, remember, that's a symptom of sleep problems, is that you have daytime sleepiness. They would then put them to sleep with all this fun stuff on them, kind of going through their normal routine. So you would read a book if that's normally what you do to fall asleep. And they study them overnight, usually about 6 in the morning. They've collected the data that they need, and a physician would interpret that. So this one doesn't show, they base them based on, remember our chemistry profile, we counted how many items they did. Well, with this one we could do 1, 2, 3, 4, 5, 6, 7, 8, 9. This would be a 9-lead sleep study. Most of them anymore are going to be many more than that. So let's look at what we've got. We've got level of consciousness. So they've looked at electrical activity. Here's the chin, and an EMG is looking at electrical movement of a muscle. So here's the recording from movement of that chin. Here's leg movement. Here's chest movement, and when the chest moves, you should have airflow movement. And if the chest is moving and air's coming in and out like it should, your heartbeat pattern should stay normal, and your oxygen level should stay normal. Let's look at this one. Do you see here the chest is moving, but look at these periods where there's no airflow. Chest is moving, no airflow. Chest is moving, no airflow. Chest not moving, no airflow. Chest not moving and no airflow. And this person has what's called mixed apnea. There are periods that are caused by obstruction, blockage, like obstructive apnea. And there are parts where it's central apnea. The brain's not sending the signal to the chest to breathe. When that happens, can you see it's changing the electrical pattern of the heart, the EKG, and their oxygen levels are rising and falling with those episodes. And you can see they have multiple ones of those. So look how this one's much more leads have been taken. The data from many more leads has been taken. And the physician then would diagnose what's going on with the patient and then come up with a plan. So if it's obstructive apnea, they're put on a machine, a CPAP machine is one of the treatments to kind of move that tissue in the back of the throat out of the way. There are dental appliances that might be used. They might have some surgical procedures done. All right, well, we are done with this lecture on the pulmonary system. If you would look over your notes, and I will post the notes for blood gas interpretation. It'd be nice to kind of preview those before we do that for our next class. If you have any questions, you're always welcome to call or email me. You have that information in the syllabus or post it on Blackboard. And I hope that you have a good week.